Hi everyone, I am Dr. Ma Abbas Helmi, lecturer of anatomy and embryology at Faculty of Medicine Ain Shams University. Today we are going to learn about the development of the respiratory system. Let's begin with the development of the nose. As we may all know that in the area of the face and here in the area of the forebrain, three prominences appear. The first prominence covers the area of the forebrain and is called the frontonasal prominence. The other two pairs of prominence, is called the maxillary prominence here and the mandibular prominence here below the maxillary prominence. Both the maxillary and the mandibular prominences are derivatives of the first pharyngeal arch. Now we are concerned about the nose, then we will focus on the frontonasal prominence. Early in the embryonic development, during the fourth week of embryonic life, two thickenings appear on the sides of the frontonasal prominence. These thickenings are called the nasal placodes. They appear because of the proliferation of the ectoderm covering the frontonasal prominence. And this nasal placode here in its center began to depress or become convex. So a depression appears on the center of the nasal placode, and this depression is called the nasal pit. So again, the nasal pit is a depression in the center of the nasal placode, and surrounding the nasal pit here is an elevation laterally and an elevation medially. Both these elevations become to elongate as the nasal pit become more deep and deep through the mesenchyme underlying it. And the two elevation here which guard the nasal pit are called the nasal prominence. This one is the medial nasal prominence, and this one is the lateral nasal prominence. And both prominence begin to begin to move to each side. This is mainly by their proliferation and to somewhat by the deepening of the nasal pit. And here the nasal pit, after it becomes more deep, we name it as nasal sac. This nasal sac will form the nasal cavity. Again here, as we can see, this is the maxillary prominence, which is colored here by green, and the mandibular prominence, which is colored by pink, and the frontonasal prominence, which is colored here by the light orange. And both the nasal placodes are here on each side of the frontonasal prominence. As we can see, the black area here is the primordial stomodium, which will form later the oral cavity. Then, as we mentioned, this in the center of the nasal placode is the nasal pit, and the light blue color here is the medial nasal prominence, and the yellow color is the lateral nasal prominence. And both medial nasal prominence become to move or migrate to each other, and they become to proliferate, so they approach each other to form the nasal septum. So the nasal septum is formed by the medial nasal prominences joined together, while the lateral nasal prominence will form the ala of the nose. This is the external external nose, and the rest of the dorsum of the nose will be formed by the frontal part of the frontonasal eminence. So the septum of the nose is formed by medial nasal prominence, while the ala of the nose is formed by the lateral nasal prominence, and the dorsum of the nose is formed by the frontal frontal part of the frontonasal prominence. So the nose here become the cranial guard of the primordium. Then moving to the nasal cavity itself, as we mentioned before that we here have the medial nasal prominence, and this is the nasal bed which become more deep. The nasal bed is caudal to the forebrain, okay, and it's separated from the oral cavity here by what's called oronasal membrane. This membrane is the oronasal membrane, and it separates the nasal cavity cranially from the oral cavity caudally. During the 6th week of development, the oronasal membrane begin to disappear and they break down. So there is a continuity develops between the nasal cavity and the oral cavity, and this continuity is the primordium quana. The quana is the opening which join the nose to the pharynx after that. Firstly, the quana is very large because the oropharyngeal membrane breaks down or disappears, and it as I mentioned before, it joins the nasal cavity to the oral cavity. However, during the 6th week, the palate begin to develop, the primary and secondary palate begin to develop, so the quana become located more dorsally, and it joins the nasal cavity to the pharynx after that. So it becomes located more dorsally and more smaller than the primitive quana, as we can see here. Then after that, on the lateral wall of the nasal cavity, the superior, middle, and inferior conchi become to develop as an outgrowth from the lateral wall of the nasal cavity. So they begin to develop after the 6th week as an elevation from the lateral wall of the nasal cavity. Some of the epithelium of the nasal cavity roof become to specialize into the olfactory epithelium, and the axons of this olfactory epithelium become too elongated to form the olfactory bulb, which will further or which will be later connected to the brain, forming the olfactory pathway. So again, the epithelium in the roof of the nasal wall, in the roof of the nose, some of it become specialized into olfactory epithelium, and their axons become to elongate to form the olfactory bulb, which will be connected to the brain. Moving to the development of the paranasal sinuses, as we know that we have the maxillary nasal sinus, the ethmoidal group of the paranasal sinuses, which are anterior, middle, and posterior ethmoidal air sinuses, the frontal air sinus here, and the sphenoidal air sinus, which lies here below the sella turcica. All or most of the paranasal sinuses are absent during the fetal life. However, in late fetal life, only the maxillary paranasal sinus become to develop, and after birth we only have the maxillary nasal sinus. Okay, we only have the maxillary nasal sinus when we are born. However, at the age of 2 years, other sinuses, other paranasal sinuses, become to develop as an outgrowth from the lateral wall of the nose. As an outgrowth from the lateral wall of the nose, as pockets evaginate from the lateral wall of the nose. At the age of 2 years, we develop the sphenoidal air sinus, while at the age of 7 years we develop the frontal nasal sinus. Okay, and at the age of 8 years we develop the ethmoidal air sinus. However, these air sinuses don't reach its adult size until adulthood, especially the maxillary paranasal sinus, which doesn't reach its adulthood size until the last molar tooth erupts. Now moving to the development of the larynx and the trachea. During the 4th week of development, the respiratory system starts to develop as a median outgrowth, which is called the laryngeotracheal groove. This laryngeotracheal groove appears in the floor of the caudal part of the primordial pharynx. As we may know that the pharynx is the most cranial part of the foregut, and it has 6 pairs of pharyngeal arches. Here the 2nd, the 3rd, the 4th, and the 5th is rudimentary and doesn't contribute to to any elements of the head and neck, and the 6th arch. Just caudal to the 4th arch, the 4th pair of arch, the laryngeotracheal groove appears, and it will be the primordium tracheobronchial tree. Here, the outgrowth of the tracheobronchial tree appears around this groove. As we can see, this is the laryngeotracheal groove, and the tracheobronchial tree, the primordium of the tracheobronchial tree, appears as an outgrowth around this slit, just caudal to the 4th pair of the pharyngeal arches. Then this pouch, or this tracheobronchial tree will form the lung buds, and this lung buds, which is the evaginated or the protruded pouch-like laryngeotracheal diverticulum. This diverticulum lies ventral to the cranial part of the foregut. Ventral to the cranial part of the foregut. So it lies ventral to the future esophagus, and as this diverticulum elongates, it becomes invested, or it spread or invade the surrounding splanchnic mesenchyme, and it elongates. Like here, this is the beginning of the respiratory diverticulum. Then it divides to form the lung buds, and these lung buds invade the surrounding mesenchyme to form a globular respiratory bud. This globular respiratory bud, which was first single, then it divides to form the future lungs. Then this laryngeotracheal diverticulum soon becomes separated from the primordial pharynx. However, it maintains a connection or a communication through the laryngeal inlet. Okay, it through the laryngeal inlet, both the laryngeotracheal diverticulum and the primordial pharynx are connected together, which will become the laryngeal inlet after that. A longitudinal septum, this septum called the tracheoesophageal fold, develop in the laryngeotracheal diverticulum, and this septum approaches from side to side, from these two sides, till it separates the trachea ventrally from the esophagus totally. So again, a septum began to develop, and this septum formed by folds called the tracheoesophageal folds, and these tracheoesophageal folds approach each other and they fuse to form a partition. This partition, the tracheoesophageal septum, develops by the end of the 5th week to separate the trachea ventrally from the esophagus dorsally. And after that, the trachea become obliterated with the proliferation of the epithelial cells that line the trachea. Between the weeks 6 and 10, the trachea is completely obliterated, and after that, holes begin to appear in this tracheal plug, so the trachea become reopened or recanalized again at the end of the 10th week. Moving to the development of the laryngeal cartilage. As we may know, this is the copula or the hypobranchial eminence. This is an outgrowth on the floor of the pharynx against or at the area of the 3rd and 4th arches. The hypobranchial eminence divide into cranial part and caudal part. The cranial part will form part of the tongue, the most dorsal part of the tongue, while its caudal end, the caudal end of the hypobranchial eminence, will become or will differentiate to form the epiglottis, which will form the guard of the laryngeal inlet, which is converted from a slit-like here, a slit-like shape, to a T-shaped laryngeal inlet, and the arytenoid and other laryngeal cartilages become to develop from the neural crest cells that migrate from the 4th and 6th pharyngeal arches. So again, the neural crest cells which are present in the 4th and 6th pharyngeal arches will form the cartilages of the larynx, which means the thyroid, the cricoid, the arytenoid, the epiglottis, not the epiglottis, as we mentioned that the epiglottis forms from the hypobranchial eminence or the copula. The other laryngeal cartilages forms from the neural crest cells that are present in the 4th and 6th weeks and 6 pharyngeal arches. As I mentioned that in the early development, both the esophagus and the trachea were primarily one tube, then a septum begin to separate them, and they end by the end of the separation. The trachea lies ventrally while the esophagus lies dorsally. So what happens if the septum doesn't continue to separate the trachea and esophagus totally? There will be some forms of congenital anomalies which called tracheoesophageal fistula. Fistula means abnormal pathway between two tubes. So the tracheoesophageal fistula has many varieties, which may be that the cranial part of the esophagus is fully separated from the trachea. However, the caudal part isn't separated, they are connected, and of course the newborn will suffer from vomiting, and while he is or she is breastfeeding, the milk wouldn't reach the stomach if the esophagus become blind or doesn't continue its passage. So there will be vomiting, and also the gastric juice or the gastric secretion will reach the trachea through the fistula, and this will cause pneumonia or respiratory tract infection. Another form is the cranial part is separated and the caudal part is separated, but the separation isn't total. So we have the trachea connected to both the esophagus, the cranial part of the esophagus, and the caudal part of the esophagus. And this anomaly is mainly due to the abnormal growth or the absence of continuity or failure of continuity between the cranial part of the esophagus and the caudal part of the esophagus. As I mentioned before, the symptoms or the baby will suffer from the same symptoms as the previous one. However, some of the milk may reach the stomach through the trachea from the upper part of the esophagus to the trachea, then through the lower part of the esophagus. Another form of the trachealesophageal fistula is fistula to the upper part of the esophagus, which is also the continuity here also is absent between the upper part and the lower part. And the last one is the presence of esophageal continuity. However, the septum didn't include the caudal part of the trachea, so the reflux of the gastric content will reach the trachea. And here there is no reflux to the trachea because the only problem here is the loss of the continuity between the both parts, or between the upper and lower parts of the esophagus.
Now moving to the development of the lungs. As we have learned before that the respiratory bud develops at the caudal end of the laryngeotracheal diverticulum during the 4th week. This bud soon divides into two outpouching. These outpouching are the primary bronchial buds. These buds grow laterally into the pericardio-peritoneal canals, which are the primordia of the pleural cavities. Then a secondary and tertiary bronchial buds soon develop. So together, as we mentioned, that the lung buds are surrounded by mesenchyme, and this mesenchyme differentiates into the connective tissue and the cartilages, connective tissue of the lungs and the blood vessels and the cartilages of the bronchi. During the 6th week, then the main bronchus here, as we mentioned, subdivide into secondary bronchi, which forms the lobar bronchi. Then the secondary bronchi will divide into segmental bronchi and intersegmental branches, and so on. So we have 10 segmental or third order bronchi on the right side of the lung, and 9 on or 8 on the left side of the lung by the 7th week of embryonic development. As this occurs, the surrounding mesenchyme also divides and forms the bronchopulmonary segments. By week 24, approximately 17 order of branches have formed, and thus respiratory bronchioles have developed. The respiratory bronchioles have developed by week 24. After birth, additional 7 orders of airway will develop after birth till we reach the age of 8 years of childhood. So the total bronchopulmonary segments will be 24. As the bronchi develop, the cartilaginous plate develop from the surrounding splanchnic mesenchyme, as we mentioned, and the smooth muscle and the connective tissue and the pulmonary connective tissue and the capillaries are also derived from this mesenchyme. So as the lungs develop, they acquire a layer of visceral pleura here. As this divide, this is the splanchnic mesoderm, which the lung buds invade, and it will form the connective tissue, blood vessels, and so on, as we mentioned before, of the lung. And also it will form these lung buds will invade the primordial pleural cavity, so they will have a visceral layer of pleura derived from the splanchnic mesenchyme. With expansion of the lungs and the pleural cavities grow caudally into the mesenchyme of the body, and soon it will lie close to the heart. Again, this is the lung buds here, the bronchial buds here, invading the pericardio-pleural canal, and this become to enlarge, invading invading the pericardio-pleural canal, and then they become ventral to the heart here. So the pleural cavities, because of the expansion of the lungs, the pleural cavities become ventral to the heart within the pericardium. This are due to the expansion of the lungs and the pleural cavities caudally into the mesenchyme of the body wall. Now we move to the last part of this lesson, which is the development of the diaphragm. As we know, the diaphragm is a dome-shaped musculo-tendinous partition that separates the thoracic and the abdominal cavities. It is formed from or develops from 4 embryonic components. The first one is the septum transversum, the septum transversum. The second one is the pleuroperitoneal membranes. The third one is the dorsal mesentry of the esophagus, and the last one is the muscular ingrowth from the lateral body wall. Muscle invades the previous components. The muscle cells or myoblasts, which are present in the lateral body wall, invade the previous 3 components. First of all, the septum transversum, which is here, grows dorsally from the ventrolateral body wall. This is the ventrolateral body wall, and it grows dorsally to form a semicircular shelf. This semicircular shelf, which separates the heart, as we can see the heart cranially, from the liver caudally. So this semicircular shelf, which is the septum transversum, separates the heart cranially from the liver dorsally. Okay, and it arises from the ventrolateral body wall. This septum transversum will form the central tendon of the diaphragm. Will form what? The central tendon of the diaphragm. As the head folds ventrally during the folding of the embryo, when there is a cranial fold, this septum transversum forms incomplete partition between the pericardial and the abdominal cavity. And as I mentioned, it separates the heart from the liver, so it divides the abdominal cavity from the pericardial cavity, but incompletely. And during the early development, a large part of the liver is embedded into the septum transversum. So we have the peritoneal folds that is attached to the diaphragm because the liver is embedded into the septum transversum during the embryonic life. The septum transversum expands dorsally and laterally to fuse with the pleuroperitoneal membranes and the dorsal mesentry of the esophagus. Moving to the second part of the pleuroperitoneal membranes, which will form a part of the diaphragm. These pleuroperitoneal membranes during the 6th week expand ventrally until their free edges fuse with the septum transversum and the dorsal mesentry of the esophagus. So what are the pleuroperitoneal membranes? What are they? They are folds. These folds appears on the inside of the thoracic wall, and these folds gradually separates the peritoneal canal or the peritoneal space from the pleuroperitoneal canal, from the pericardio-peritoneal canal. Again, these folds project into the pericardio-peritoneal canals. This space is here, the white space here is called the pericardio-peritoneal canals, and these canals become too obliterated, or their size become to diminish because the gradual growth of folds called pleuroperitoneal membranes. Then, as we mentioned, these pleuroperitoneal membranes will fuse with the central tendon, which is derived from the primordium, from the septum transversalium. Firstly, the septum transversalium lies in the cranial part of the embryo. Then it migrates distally because of the growth of the embryo. As I was describing before, that this is the central tendon of the diaphragm, and this is the crura of the diaphragm developed from the dorsal mesentery, and this is the rest of the diaphragm. And these holes here, which should be absent, these holes represent the embryonic connection between the pericardio-pleural cavity and the peritoneal cavity. As we mentioned before, these cavities or these canals should be obliterated by the fusion of the pericardio-peritoneal of the pleuroperitoneal membranes, which fuse with the septum transversum. However, if these membranes don't fuse with the septum transversum, they will result in what's called the congenital diaphragmatic hernia. and the congenital diaphragmatic hernia is more on the right side than on the left side. On the left side there is no hernia here, however there is a hernia in the right side here, and this is the opening for the inferior vena cava, and this hernia on the is more on the right side because the pleuro pericardioperitoneal canals on the right side is obliterated later or after the obliteration of the pericardioperitoneal canal on the left side. As a result of the presence of this hole in the diaphragm, parts of the abdominal organs will herniate into the thoracic cavity. Here, as we can see here, part of the liver, intestine herniate into the thoracic cavity, and this doesn't only push the lung to the opposite side, but also it affects the development of the lung. As we know, the lungs to develop normally, they should have space, an available or adequate space to develop. However, if hernia occurs, this space will be reduced, and not only the side of the hernia, the lung on the side of the hernia affected, but also due to the thoracic organ being pushed to the other side of the lung will be affected, and these babies will suffer from pulmonary atresia or even a genesis of one lung. That's all we have to learn about this chapter, and thank you all for listening, and hope you this lecture is helpful. Thank you guys. Goodbye. Then the dorsal mesentry, which we mentioned before, which we described before, the dorsal mesentry of the esophagus here will form the median portion of the diaphragm, and this median portion of the diaphragm will form what here? The crura of the diaphragm. The crura of the diaphragm. So the crura of the diaphragm are derived from the dorsal mesentry of the esophagus. During the 4th week, the septum transversarium are located or lies opposite the 3rd to 5th cervical somites. Again, during the 4th week, the septum transversarium lies opposite to the 3rd and 5th cervical somites. And during the 5th week, myoblasts migrate from these somites to the developing diaphragm, bringing their nerves, their nerve fibers with them. So consequently, the phrenic nerves that supplies the motor or provide the motor innervation to the diaphragm arise from the ventral primary rami of 3rd, 4th, and 5th cervical spinal nerves. Also the phrenic nerve supplies the superior and inferior surfaces of right and left domes of the diaphragm, gives sensory fibers to the superior and inferior surfaces of the right and left domes of the diaphragm. However, after rapid growth of the dorsal part of the embryo, it results in an apparent descent of the diaphragm, and by the 6th week, the developing diaphragm is at the level of the thoracic somites. So the phrenic nerve now have a descending course because the diaphragm or the septum transversum lies first at the opposite the 3rd somites, while now it lies at the level of the thoracic somites.